Let's talk about the use of venetoclax, the BCL2 inhibitor, with hypomethylating agents, LODAC, in older, unfit patients with AML. Dan, you want to walk us through those?
Yeah, well, I mean, I think this has been around for a little while now. Probably a fair amount of comfort with it. Published phase 1 studies, large phase 1 studies that have led to the approval of venetoclax plus a backbone therapy, either low-dose cytarabine or hypomethylating agent, azacitidine or decitabine, in the setting of a newly diagnosed unfit or older AML patient. And I think the responses, at least with the hypomethylating therapies, the expectation is a response rate of somewhere on the order of 70%. I think we're still, a little bit in evolution on durability and survival, but at least right now they look fairly good and promising. These are pretty safe therapies. The concern for tumor lysis syndrome is pretty low when the tumor lysis syndrome mitigation techniques that were employed in the studies are used, and the early death rates are very low. So I think the venetoclax remains, and of course this led to approval a little over a year ago. So I think the Venetoclax-based therapies for this population are really a significant move, advance, and have really worked their way into the standard of care. And I think there's lots of things that we could do to improve this.
Okay, Naval, how about combinations of venetoclax with intensive chemotherapy like Ida-Flag?
Sure, yeah. So this is, of course, a much earlier kind of study development. This is as compared to the HMA venetoclax or low-dose RC venetoclax that have more established track record, publication, follow-up. But this is a study that was presented from our center. One of our fellows, Dr. Abu Dale, working with Dr. Donato, presented the results of a FLAG-IDA, so fludarabine, cytarabine, idarubicin intensive induction with venetoclax in relapse population, initially kind of in the phase 1b safety portion, and now moving to both frontline and relapse cohort. I will have to say with this study, it's very important that the study from where it started has evolved quite a bit in dosing. So we initially started with standard MRC dosing, UK MRC, FLAG-IDA dosing with venetoclax, and only 14 days of venetoclax. And what we saw in the first 8 or 9 patients, we had 4 patients during the first cycle at the nadir of myelosuppression who had severe infections, required ICU. They recovered, came back, and eventually 2 of them actually went to transplant and are still doing well. But that made us very concerned. So we dropped the dose of IDA to 6 for 2 days, RC to 1.5 gram per meter square for 4 days. And with that modified regimen, actually, it's a small change, but actually really changed the myelosuppression infection. So then the relapse cohort has continued. We've treated about 20 patients. The response rate, CR/CRI rate, is 75%, which, I mean, in relapsed AML is really amazing. It's a small number, so we have to see if this will continue. And more of half of them went to transplant. So it's looking good. Now, in the end of the day, the survival, unfortunately, is not that great. It's about 8 months in relapse, which is not bad, but it's not comparing to what we were hoping when we saw the high response. The frontline arm is going on. It's showing 100% response, but we do get high responses in frontline setting. MRD negativity is being achieved in everybody. So I think there is excitement for this, but I have to be cautious about this. This is not something to do at home at all. That's why I mentioned the ICU stays, etc. This is a great option if you have a 35-year-old, failed 3+7, you want to call your large academic center, and say, hey, would you do this? Can you do this? This could be something that could take him to transplant and get the patient through. But if you do this home, I think the mortality could be extremely, extremely high. So it's being evaluated, it's being expanded, and we will have more data. But at 75% is a very, very good number in relapse.